LinkedIn audio. Today, as advertised, we're going to be talking about patient safety and medicine information. We're going to be talking about safety and medicine information, and we're hoping that people will join us as we go along. For people who don't know myself and Jenkeo, my name is Temitope, Day as obviously as on the screen. I am the head of medicine management for First Community Health and Care. We are a social enterprise. We deliver NHS service, and we obviously use that obviously as the pharmacy, so the pharmacies for the organization. And welcome, Erica. Lovely to have you join us. Thank you for joining us. I'm basically just introducing myself and introducing the program. So for you, obviously, to recap, my name is Temitope. I'm the head of medicine management for First Community Health and Care. We are a social enterprise, and we deliver NHS services here in the UK. And basically, our role is more in the community. So not in the acute hospital or in the what you would call a district hospital. However, we look after community hospital. So people that have been stepped down from an acute, and we look after people in their own home. And I look after everything, all things medicine basically. And I've got my co-host with me today, and her name is Jenkeo, and I'll get her to introduce herself. Again, as advertised, we're going to be talking about all things patient safety and medicine information as it relates to how we manage patients. Jenkeo, can I hand over to you?
Yes, thank you very much, Tammy, for introducing yourself. Good evening, everyone. I think for the purposes of this LinkedIn, it's like we could actually say Happy New Month because we tend to do this podcast every month. Yes, my name is Jenkeo Olunloba, and I'm also the head of medicines management for a community interest company, social enterprise in the Medway environs. We provide services likewise, like as Tammy rightly introduced, mostly NHS commission services. And I tend to deal with all matters related to medicines. And tonight or to this evening, our focus would be on patient safety and medicines information services and how medicines management play an important role in this area. I think it's probably best to kickstart because it's important that we utilize the time that we've got. So patient safety, when I think about patient safety, you have to look at, you consider the patients and, what has been put in place to ensure that, patients are being considered in all areas. Medicines management, when I think about it, patient safety and medicines management are critical components to healthcare, and it's ensuring that patients receive appropriate treatments whilst minimizing risk associated with medication use. So although the medicines management team is separate from the patient safety team, we do work as an integral part of the team to ensure that patient safety is being embedded within the organization. I am going to talk about patient safety as a whole, but I am going to also introduce in the conversation today the patient safety incident response framework, which is the new framework that's been embedded, that's been implemented within for all healthcare organizations. And I say all healthcare organizations simply because this is the way, we are reviewing patients' incidents, any sort of safety incidents as a whole. There's a lot of changes that's been put in place, and this I would call it PSIRF. So welcome everyone. For the purposes of people that are joining, I'm going to be talking about patient safety and also introducing the patient safety incident response framework, which I would call as an acronym PSIRF. So knowing that patient safety, is an integral part of, ensuring that patients receive the right medicines, reviewing all the risks associated with it. Patient safety incident framework offers a structured approach. And what it means is that we are able to understand and improve every aspect within healthcare, especially when it comes to medicines. The focus tonight is about medicines management. It is important that, when I think about it, because it's still a new a framework being implemented. I mean, for my organization, some organizations are far and some organizations are not even there yet. So it's important to appreciate that, organizations, it's still a work in progress for most organizations in the healthcare system. But it's a framework that has been widely welcomed, because we need to consider there needs to be a shift in the mindset. So from a head of medicines management point of view, how have I played an important part in ensuring that this has been implemented? It's ensuring that there is a policy. That policy has been authored by our patient safety lead, which is the head of patient safety, but making sure that also when I'm looking at from a medicines angle, that medicines is included in this. We've had our policy. I'm very pleased and excited to actually say that our policy from a PSIRF point of view has been ratified by ICB, which is our integrated care board. And those are the individuals that tend to commission most of our services. So if you're in any organization or you're looking at, okay, how are things working within the healthcare system in regards to incident patient safety, it means that they have to go through this process of having the documents being ratified to ensure that, it's not because they are trying to scrutinize what you're doing. It's just to ensure that we have got this accountability and this working in partnership being embedded. From a medicines management point of view, it's important that when this document is being developed, you don't exclude subject matters like subject experts. So from as the pharmacist in the organization, it's important that when we're writing this policy or reviewing this policy, you had your own expert knowledge into how the incident framework will be formulated or developed within your organization. So the whole patient safety or patient safety incident framework, it's designed to help healthcare organizations respond to patient safety incidents. So when we're considering it, and I'm going to give some time for Temi to talk also, is that when we think about patient safety, we also have to swing to the patient safety incident aspect, because when I talked about the initial definition of patient safety, but I also needed to consider the extreme end when there is an incident. And this patient safety incident framework, it gives us it provides a different approach to how patient incidents are being reviewed. So there is a shift in the mindset. In previous years, when we've had, serious incidents being reviewed or being, investigated, it's always been it's always felt like it was on a blame culture basis. Although most organizations simply say that, it's not a blame culture, but you look at it, how all the processes have been investigated. It's about looking at the root cause, why the individual involved in the incident has resulted to, making an error. But from a PSIRF and patient safety point of view, we're looking at it holistically from a systematic point of view to see how the system as would need to sort of respond to certain incidents. So, and it provides a very robust methodology. So, like I said, it's a shift in the mindset, it's a shift on a new way of us working. And it's, in a sense that everyone is going to be working in the same light. So private hospitals, acute hospitals, the primary care, which is the GP land, needs to also jump on this sort of new patient safety incident response framework. And the way we look at it is also considering the patient into it. It encourages thorough investigation of incidents, but we're not looking at from a root cause point of view. So you're looking at it from a systematic, so we're looking at it holistically. And it also focuses on how, it focuses on using insights that you gain from incidents, how you analyze incidents. So I would give an example, and I'm just going to probably pause for a while just to see what Tammy has to say from a patient safety in her organization. So within our organization, I'm going to say this, and I'm going to be hoping and praying that no serious incident has happened within the organization. There are various patient safety measures that we've put in place, to which I'm going to talk about later. But one thing we had to review from the patient safety incident response framework policy is to review that what are the key priority area. I, as the head of medicines management, had to put my hands up to say, can we make medicines a focus? Can we ensure that we're reviewing the processes for medicines within our organization? And also, not because we do have a lot of incidents, but because we want to make sure our patients are getting a better care, to make sure that all the risks that the patients could be exposed to are being considered. So I'm then reviewing all incidents from a thematic point of view. So it might not be a major incident that's occurred within our organization, which usually doesn't occur like that. And I'm saying that, and I'm also praying to say, fingers crossed, this is not the case. But also looking at it as a point of what could be the trends of what's happening in the organization. How else can we change our processes? How else, from an organizational point of view, or from a systematic point of view, can we improve things? So we're not just focusing on the individual, because that individual involved in that incident also needs support, but we're also looking at it in terms of from a patient angle as well. Tammy, do you want to add to it as well?
Thank you for laying that foundation around patient safety and the PSIRF. And I think the PSIRF is quite important in our organization. Here we look at, like Jenkeo rightly said, the patient safety team actually take leadership on that. However, each team, why I propose to each team is to decide what they want to focus on around medicine for PSIRF. I took that approach because I find that I think you have to almost look at what is happening with the team and the culture and the mindset to decide what is the best way to approach it. So I felt that, and maybe it's my training as well, that people are more accountable when they pick what they want to do, or what area that they felt that they need support, because they're accountable because they actually pick that area, that's the area they want to focus on. Obviously, I will give them guidance if I think, okay, can we do it a bit slightly different? The other thing is to highlight patterns of error and see if that's an area we want to focus on. So, for instance, high-risk drug. One of the high-risk drug is insulin. So, one of the areas that is a focus that the team decide they want to do insulin, which I was really interested in as well, because that's an area that right across the country, we know that insulin has always been an area that there is challenges because of different way of doing it. So, I've done it in such a way that I allow the team to come up with what they think is the biggest challenge around medicine, and then we create a PSIRF process around that. So that's how we've done it in our organization, and that is really help because then the team get to take ownership of what they said they wanted to do in that respect, and we create that process and obviously set meetings and set different strategy for PSIRF around what the team has created. So for us, that's what we've done around PSIRF. That's really worked. Is really moved. Is actually open up some things that we didn't know is possible. Is open up things that we didn't even know is there. Is open up conversation with the integrated care boards. Is open up conversation with the region around. Is open up conversation with the diabetic network for Kensori and Sussex area. So is actually created more awareness. The staff are more aware. The staff are more, looking at things. It's created opportunity to talk about peer review, it's created opportunity to talk about actually how do we have a conversation with a diabetic specialist? Do we need a diabetic specialist in certain area? So it's created some very interesting discussion and interesting work that we are now, different stream of work that we're now working on. So definitely the pharmacist needs to be involved, because if they're not involved, then certain decision will be made around medicine that you're not aware of. Thank you.
Thank you very much, Tammy. I just wanted to take the consensus from the room tonight. How many of us have heard about patient safety? If you want to let us know what you're doing within your organization, and if it's still a very new concept, how do you intend to approach it from a medicines or from your own department specialist point of view? I'll give people the opportunity to. Thank you very much, Bisola. I think we could move Bisola. Can we get Bisola to speak, please? Hi, Bisola.
Hi there. Good evening, everyone.
Good evening.
I was just going to say, patient safety-wise, I think that's a universal requirement, isn't it, in delivering any form of service?
That's correct.
Surely. And therefore, we have, of course, you always have the national sort of options, and you have your local options. And in terms of what are we doing in my organization, I primarily work with ICB, medicines optimization, and general practice. And we have our own in-house way of accumulating that information, which is, something that everyone's adopted, regardless of role, to ensure that we have that visibility and we have the right environment to learn from one another. So it's a sharing practice, good. What is the word I'm looking for? Making sure that everybody doesn't feel that they're alone in any ways. It's an opportunity to learn. And in some cases, of course, you divide that into whether it goes to the patient or whether it's something that was seen before it goes to the patient. And whoever is involved in that patient journey, as an individual, needs to learn from their own potential mistakes as much as for others to learn from that as well. We have got a system of reviewing as a group once a month, so everything gets brought together, because of course where people work different times of the different shift patterns, so that everybody has an overall knowledge of what's happened as months has gone past. And beyond that, of course, you've got your national sort of CARS system and things like alerts as well that you review, and some of it might not be necessarily reflexive of your own practice, but of course you can always learn from every situation that has happened. So it's an evolving situation in my practice, and it's very much at the forefront of everything that we do. And it is not a culture, it's not a blaming culture in any way, shape, or form. Potentially there could be different layers where patient safety can be compromised, and it could be on the individual side or a system-wise side, process-driven, and every other possibility that there can be. But nonetheless, regardless of where it's come from, it's always a learning opportunity, and the focus is about ensuring that it doesn't get any worse than it is, and to ensure that the impact is minimized as much as possible so that it doesn't happen again. And that really is the focus, that it doesn't happen again. And what do you put in place to ensure that that does not happen? And you just want to plug the holes wherever there might be to ensure that it doesn't happen again. But yeah, that's sort of an overview of what's going on in my practice.
Thank you very much, Bisola. It's lovely to hear what Bisola is saying in terms of what happens within organization. One of the key words for me is when she said, it's not a blame, we're not apportioning any blame to any individual. Another thing that we pointed out is the time that they're setting apart to review, to consider the incident as a whole and looking at, what you can learn from it. So we talk about lessons learned. So you're looking at it from a patient safety incident response framework is like looking at it from the learning responses. How do you respond to those learning? So when we get lessons learned, then what next? So this is where we then think about patient safety from a broad point of view, yes. But then what are we getting from it? Yes, we've learned this lesson. So what's next? How do we need to then think about it from a preventative point of view? Do we look at patient safety or medicines management from a point of implementing certain changes? But it's a lot of, I think there needs to be a shift in that mindset. And I think this is where the whole PSIRF is coming into play, even right up to how we are having discussions, the languages that needs to be that you need to use. So rather than, I was speaking to my patient safety incident lead, and we were talking about the conversation. So rather than having an interview with a person rather than saying you wanted to do interview for someone that's involved in an incident, you say to them that we would like to have a discussion so we can understand what's happened. There are sessions where we do an huddle. So rather than doing you're saying that you're having a serious incident meeting, we're saying we're having a huddle just to brainstorm on why we've had this incident, what are the other areas that we need to consider into this incident. And I think it's very important. It's a very important part within healthcare that needs to be watertight. I mean, all other organizations have got different way of doing it, but I'm hoping with this new PSIRF framework, the new framework, we're able to sort of embed the whole processes effectively within healthcare. And obviously, like Bisola rightly mentioned, then you're able to deal with issues, on ground, but also you're also able to get certain information from it. Yes, it's a very, when I say it's a fairly new concept or framework within my organization, we are over almost a year now that we've been discussing the PSIRF. But one thing we've also looked at is from a quality improvement point of view. So it's we are looking at it from patient safety and quality improvement, how we can improve on our services, if there are any innovative ideas that we can look into to ensure that, our patients are getting the best possible care out there. So, there are a few things that we do, and thank you so much, Bisola. I'll probably give other people opportunity to speak. Is there anyone that is also doing anything from a patient safety point of view as well? So you might not think of it as patient safety, as in, because like I said to you, we do have a patient safety individual, Erica. Can we get Erica on stage, please?
Erica, you need to raise up your hand.
She has.
Oh, sorry, I just saw that. Give me 1 second, please. Give me 1 second. Oops.
So whilst Erica is getting on the platform, it's important to realize that even in, we work in a community interest, community health services, it's important to recognize the collaborative work in here. So we can't do patient safety in silo. You can't possibly think you're going to do medicines and not involve patient safety, and vice versa. Patient safety can't say they're going to, be working as a patient safety team without the involvement of the medicines management, because most of our patients, if you look at the statistics, a lot of patients are on medicines, and it's important that the whole processes with regards to medicines is being reviewed and effectively managed. I don't know what has happened to Erica, but I'm sure Erica will come back onto the platform and we'll continue the discussion. So I'm going to sort of give few examples of what we've been able to implement within the organization and what I intend to do in the nearest future from a patient safety point of view, but also from a PSIRF point of view. So, as you know, from medicines management includes all activities ranging from prescribing, administering medicines, reviewing of medications, ensuring that, we've got an optimal patient outcome. It's important that we're looking at it, that there are no incidents or any potential adverse events is being managed. We're also looking at it from a patient, medicines waste point of view. So a few things that I do as the head of medicines management is to review incidents. So it might seem a bit daunting, and I'm sure Tammy will probably agree with me that having to review all the incidents within the organization is one of my key roles, because then I have the full oversight of what's happening within the organization. Erica, could you just raise up your hand so Tammy can then rightfully put you on stage? Tammy, can I get Erica on stage, please?
I am struggling to put Erica on stage. Do you have the control?
I don't. Oh dear.
Okay. Bear with me. I'll give you another go. Bear with me.
Okay. Erica, just put your hands up. I'm hoping your hands is not hurting you by virtually raising it up. But I would go ahead. I review all the incidents. And why am I doing this? Is to ensure that there is a full oversight about the incidents that are happening within organizations. And we're not looking at it from a point of just the organization as alone, but from a whole system point of view. So Tammy rightfully mentioned the fact that we collaborate with the integrated care boards, but also we collaborate with all our primary care colleagues and our acute colleagues. So if there are any incidents that needs to be reviewed from a system approach, we can also share lessons and, consider what are the trends happening. So I think about a year and a bit ago, or probably going to 2 years now, there were issues about, control drug loss within my organization, to which I obviously sought out sort of advice from, different links or different CD link, which is the control drug accountable links. But it was very important that we are also, sharing this intelligence with the acutes, which they also echo that they were having this sort of incidents as well. So we sort of shared what we would be doing to provide, a better patient safety from a medicines management point of view. Erica, thanks for joining us. The floor is yours.
Thank you for having me on stage today. So my experience is based in two parts, personal and professional. I come from a healthcare and research background, and I find that these 3 C's for me are really helps me navigate the collaborative, the collective, and the concise inputs and outputs. So if you think about the collaborative piece, it's, what we put into our care. So our awareness, our accountability, things like that. And then when we think of the collective, it's really the experience, so how we communicate, our patient-doctor relationships. And then the concise part is the output. So one piece is, the size of medication labels, the, effectiveness of the easy open tops, or but I think overall, your mention of the interview piece or the the collection of data piece in a one-on-one setting, I think that does break a lot of barriers because many times patients are not comfortable, at their doctor's office. Maybe it's a new doctor, or maybe they're not comfortable because, they have some bad habits that they don't want to share and, things like that. So I think having that one-on-one experiences minimizes the bias as well as pours into, those 3 C's. So the collaboration, the collection, as well as the conciseness. So I have a bunch, to say in regards to, consenting and, data management and things like that. But overall, I think for the human piece in a virtual world, I think that we need to leverage, like you said, these audio spaces to really get the patient's experience, to build on those vendor relationships, those doctor relationships, and, things of that nature. So thanks for allowing me to speak today.
Thank you very much, Erica. It's lovely to put it in those 3 C's, because when we consider it from a collaborative point of view, from a collective and concise point of view, I think this is all patient safety looking at it. And I also want to echo the fact that involvement of patients one-on-one, or even getting their point of view and understanding a patient's point of view is very key to ensuring that you get a better patient safety outcome. And, in past years, you've had, cases where you've had incidents or patient safety has been compromised and you've never considered the patient. Yes, we do the duty of candor, to which you explain to the patient that there's been an incident, but you never consider what else, what else would the patient like to see better work within the system. So it's very good. Thank you very much, Erica, for saying that. And I'm sure, you've been very patient enough trying to get on the platform. Thank you. I was saying before about, reviewing incidents. Other things that, from a medicines management point of view is that intelligence. And I like when Erica mentioned the sort of intelligence that we get. So from a data perspective, I get some data or information from the medicines incident, but also I get intelligence from, when our patient safety colleagues go out there into other organizations, getting information about what's going on, not just from a medicines point of view, but also from a patient safety point of view, and if there are other things that we need to consider. So there have been different things that have been looked at. So I look at it from the patient. I had a meeting with the head of patient safety a couple of weeks ago, and we're discussing, discharge in general. And yes, we might have everything going smoothly, but there have been issues in terms of from a transfer of care concerns that might impact patient safety as a whole, meaning that we need to ensure medicines were as an integral part of the patient's care has been looked after effectively. But also, we're also considering that, is there anything that we could put in place from a system point of view that would ensure that patients are receiving a better care? So it's not just thinking about medicines alone, but we're looking at how we work together. So I like how Erica put those 3 C's, because it just seals it. It just makes it perfect. And it gives you the opportunity to think, actually, if we think about it from a collaborative or from a collective point of view, or from a concise, making sure everything in terms of your, prescribing or whatever needs to be done is concise and it's in line with the formulary, it's in line with the policies, then that those are preventative methods to ensuring patient safety are being upheld within your organization. And also from a patient point of view, it's also looking at how patients are involved in patient safety. So within my organization, I'm also I think it's always good to celebrate the successes and how far we've come from a patient safety and medicines management within the organization. We also have what we've introduced, or should I say that from the patient safety incident response framework, we've also been able to get an approval to get patient safety partners. And these are not healthcare or, individuals. They're actual real life patients that will be involved in patient safety as from a patient point of view. So they are also involved in the whole process, listening to our patients, going out there, seeing how they can advocate for patient safety out in the community. Another key aspect to my role, amongst everything that we do, and I'm sure Temi would probably interject in a bit, but I think this is probably my show. It feels like this is my show. But I think, thank you, Temi, for giving me this opportunity, I would say. Quality improvement before is, what we've learned from patient safety incidents, and how we've been able to embed it into our organization. So we do a lot of training, and one of the things that I have planned by the end of the year is from reviewing incidents within my organization. I've identified as a particular service that has had an increase in incidents. So you might look at it in two ways. This service of reported incidents, and some services haven't. That could be one way. Or it could be that the fact that from a systems point of view, something isn't right from a systematic way of working within that service. So we're I'm reviewing the themes and in the incident that they're having. And I'm having a session, like a training session, an educational session for the whole team, the whole nursing team, to be involved into having that, taking ownership about why this incident has happened. What else can we do from a systems point of view? Do we need to introduce innovative ideas? Do they have innovative ideas that could buttress their patient safety practice out in whilst they're working? And it's just not looking at, so I'm not looking at it from a head of medicines management and telling them what to do, but like Temi rightly said before, it's about what they want to do, how they want to take ownership about patient safety in there, and ensuring that it's in line with guidelines, is ensuring that it's in line. Of course, we're not breaking any laws, but making sure that every individual, every clinician, every patient, everyone involved in patient's care take responsibility, and we get that support. So there are training and education to enhance staff knowledge and skills in safe medication management, but also looking at how processes would change. And this is it. At the moment, I am very pleased to say I am actually going through a quality improvement training. And that's to, I'm not just looking at it from a medicines point of view, but also looking at it from a patient safety point of view, that if we're looking at redesigning the process, reviewing the process, there are innovative ideas that could come out from this. And how do we make it into a quality improvement project, for example? I'm going to pause and I'm going to give Erica time to speak. So can I get Erica to be put on stage, please?
Thank you so much for bringing me back on stage. I think you both, Jenkeo, I hope I pronounced that correctly, as well as Temitope. Right. Sorry, I'm chewing my lunch right now. Apologies, but I wanted to give an example here of why I think these 3 C's will work. Let's think of that new wonder drug, Ozempic, for instance, where it was originally for, a said indication. But then as people lost weight, it became like a wonder weight loss drug. That is a good example for this collaborative, collective, and concise, because we have this group of patients that's all for it for, weight loss. They're willing to buy it over the counter. They're not questioning if it's a designer drug or a counterfeit drug. They just want the weight loss. Mm-hmm. And we need that data from those patients to solidify, lot numbers and results and side effects. And for the people that's doing it for diabetes, we need that patient input to say, my results are good or my side effects are bad, and et cetera, et cetera. So together, we know that now Ozempic is the diabetic weight loss, phenomenon of the world, especially here in the States with, weight being a number one, comorbidity. So I just wanted to share that example. I'm happy to be here. Healthcare and research is like my passion. So thank you, ladies, for allowing me to speak.
Thank you very much, Erica. And you're very right. Even though I think like you said, 3Cs would work. And when you look at it, patient safety, I think the same concept needs to be adopted across worldwide. I don't think it's subjective to a particular country. And like you said, using Ozempic as a good example, you can look at how, it's not just medicines, but looking at it from an holistic point of view, how that, we can collaborate with one another. So I say this, and this was, not just for Ozempic. We had a particular drug that was indicated especially for the diabetes. It's not Ozempic. And we were also, it was eventually indicated for heart failure. And we realized that, you can't just put those patients on those medicines. It's important that, we get information from the data. You're able to work collaboratively from different services to ensure that the patient is getting that possible care. And, it's key. I think from a patient safety point of view, it's key that I'm big on collaboration, and I'm sure, I'm sure Tammy would probably agree with me that, you can't, and I can't emphasize it enough, that you cannot work in silo. You cannot expect to uphold patient safety without, like Erica rightly said, including those 3Cs. You can't say you want to do it on your own and run with it without actually getting expertise and the knowledge of others to ensure that you're getting a better, robust care. So it's key. Thank you so much, Erica. One thing I also wanted to talk about is the use of technology. I'm gradually getting there. I'm going to be, brutally honest that I'm getting there when it comes to technology. And I'm sure Temi is probably cracking up right there thinking, oh my God, she didn't just say that out loud. So I believe technology is the way forward. And, being able to use technology to enhance patient safety is the way forward now. So from a medicines management point of view, we are considering, embedding or should I say implementing the electronic prescribing module within our organization. I'm so excited about it because, our senior management, when I say the board, are very keen on ensuring that this, software is being implemented within our organization. Yes, it has its own cost implication, but actually improves patient care from a prescribing point of view, from a monitoring point of view, and also being able to collate those data, those information effectively, and also being able to communicate those information effectively between other organizations. And that's key when it comes to medicines management. Bisala has got her hands up, and I think Erica then has her hands up. So can we get to the two ladies on stage to talk? Bisala first, please.
Hi, ladies. Hi, everyone. Rather. What I was just thinking while you've been talking is that often enough we look at patient safety from a negative point of view. That perhaps we're forgetting the positivity behind it as well. And often enough, things, because you hear a bad press or you hear about something that's gone completely wrong, and you start to then tidy up your own house, so your own process and everything, and think, well, that could easily have been us. In terms of sharing what good practices are out there, there's no platform. I don't think. I mean, social media and when I say social media, maybe LinkedIn, perhaps gives an opportunity for people to showcase what they're doing in a positive way in terms of projects that people can then learn from. So, it's just a shame that often enough it is when something's gone wrong that things have to be put in place. And of course, the ideal thing is to do it before it gets to that stage, to identify the pinch points in the patient journey or in the processes in the systems where there's slack or where there is a weak link where that needs to be that needs to be strengthened. And also as in terms of getting good practices out there where people are doing things that are just being done as a matter of course that you can learn from and use as part of your own in-house upkeep, if you like. But it is unfortunate that it is seen as a negative thing, patient safety wise, when things have gone wrong. It is a learning opportunity. It is a great, you don't want anyone to come to harm. And that's the ultimate thing that you want to avoid. So what you're wanting to do is to embrace it. I really, really encourage everyone in my organization to embrace it and really put their hands up or sometimes you even self-reflect and think perhaps I should have done things differently, or what would have happened if this had been the pathway that it's gone through as opposed to that one. So really having that, I keep saying about that open culture and that encouragement for people to share good practices that they've come to conclude themselves, as much as things that haven't quite gone the way they've planned. Thank you.
Thank you so much, Bisola. I think that's key. Ability to reflect on practices. And yes, you know what? Every time you think about patient safety, I think in previous years, it's about what have I done wrong? A lot of people consider it like, oh, something must have happened. But we've been probably talking about it now. It's about, what can we do differently? What preventative measures can be put in place? What else can we learn from, whatever is going on out there? It might not even be an incident. It might be, new initiative, new framework, learning from each other, learning from our patients, because, it's not just from clinicians' point of view, but also learning from patients. And that's where, I also liaise with our research team just to get better understanding about, from a research field, what's going on out there. The patient involvement in there is so rich. Thank you so much, Bisola. Erica.
Thank you again. I find this topic interesting, so anytime I'm taking over, just shoot me back down or say, no way, Jose. But Bisola made a great point around education. And that's what became my passion when I had made it to, what I considered my corporate role, my high-end status. It's like the more stuff I saw, the more I realized that the education piece of patient safety and medicine was really lacking. Like, yes, doctors are trained, which I didn't because I couldn't afford it or wasn't dedicated enough. But I got into research because I was like, that'll be my next best option. But as I was navigating it, I learned more about the job and the risk actually doing the work than I did in a biology or chemistry class or a management class. I learned it like on the job. So Bisola made a great point there. And then you mentioned technology. And EMR popped in my head and I was like, ooh, there's a good safety red flag or medicine red flag right there. But if you think about it on a research space, which I am in, you have these SAE reports or these adverse event reports that go to like IRBs and things like that. But where are we actually utilizing that data? And as Bisola said, not in a negative way, but where are we using that to say, maybe this drug needs a revision, or maybe this, treatment needs a revision, like they did Ozempic, it was for one indication, but now it's for multiple. So I just wanted to make those 2 points. I think this is great space, and education and technology definitely will fuel the future of healthcare. So thank you, ladies.
Thank you. Thank you so much, Erica.
Can I just butt in?
Of course you can.
We've got, if we don't mind, we've got Tolu in the house from Ireland. And if she is able, it would be nice to find out what they do in Ireland around patient safety that we can learn from. If she's not able, that's fine.
So she can you let Tolu in onto the platform, please? Hi, Tolu.
Hi, Jane. Hi, Timmy. Good evening, ladies and gentlemen. It's so nice to join this discussion this evening.
So sorry, Bisola, we will come to you. Apologies.
Oh, sorry, I thought I just jumped into the discussion. It's such a pleasure to be in your midst, and it's been an amazing conversation so far. Thank you, Jane, for all the insights you've shared. Thank you, Erica. Thank you, Bisola, and all others. Well, in Highland, the scope of patient safety is very broad with nursing. It encompasses medicine management. It goes as far as, preventing CLABSI, that's the catheter-associated infection, the surgical site management, CLABSI prevention, CORTI, and all of that. But particularly with medicine management, just like Jane has been discussing, it's more or less the same. I'll just start with the management of the controlled medication, because here in Highland is a very big issue. If you have any number at all of the controlled medicine missing, it's a very big issue. And I suppose the honors to guard this medication cupboard is on the nurses, because, like we know, we are involved in administration of the DDA. It has to be countersigned and all of that. But with the medicine management unit, they do come to the world from time to time to take audit of these medications, And well, one thing that I discover here in Highland is that the pharmacists are always in the unit at least 3 times in a week to retrieve all the medications that are irrelevant in the cupboard. So we don't stock medications for longer period in the unit. For example, I work in the cardiology unit, and most of the time we only have, all the cardiology medications available on the ward. All other medications that are not related to cardiology patients are not to be kept in the ward. For example, let's say we have a patient who came in with heart failure and has comorbidity, like, if the patient is having benign prostate hyperplasia, the patient might be on tamsulosin, Combodart, and every other medication that are not related to, the cardiology aspect. So such medications won't be kept in the ward after such patient is being discharged. So I suppose this is the work of the people in the medicine management. They are there on the ward time to time, retrieving medications that are not relevant to the patient we have on the ward. And for nurses, at the end of every shift at night, one of the things we do is to take stocks of the patient's medications. So we retrieve all the codexes and, fish out those medicines that we will be needing in the next 24 hours. So in the morning, the person in charge of the medicine management will be in the ward retrieving every other medications that are not in use. And with this, we are able to say we'll be able to control medication errors and all of that. Because, like I said, that if a control dog is missing, that's a huge problem. If there is medication error, that's also a huge problem. So we don't want to be involved, to get involved in any medicine management. And we cannot do this alone. It's such a collaborative work. The nurses can't do it alone. The pharmacists can't do it alone. The doctors can't do it alone. I suppose it's a teamwork. And for nurses, we have to be sure of you can't assume all the doctors know the right prescription. Most of the time, doctors make mistakes too. And when you are going through this prescription, you discover a lot of mistakes, and you have to, sort that out. Again, like Jane was saying, that we have to learn from the patient themselves, because most of these patients, they have one thing I've observed personally is that when I'm admitting a patient into the ward, most of them do come into the hospital with their own medications. And unknowingly to the nurses, they might have taken the dose. Let's say they come in they were here in the morning, they came into the ward in the morning, and before you got to them in the afternoon to give them the medication, they had already taken the PM dose. And unknowingly to you, you might not know. And, most of these patients might be confused. They might not be in the position to tell you, oh, nurse, I've taken my medication. So this is why medication reconciliation comes in for the nurses. We retrieve all the medications from every patient coming in from the point of admission. You ask them, have you your own tablets? And if they do, we retrieve everything and keep in the medication room. I believe that's one aspect of medicine management as well, just to prevent, overdosing the patients. The patient might have taken his or her own, and then the nurse is there giving his or her own as well. So it's such a collaborative effort. That's just what I want to say. From the doctors, the prescription, the pharmacist, issuing the medication, from to the nurses who serves the medication, and even at the point of discharge. It's our responsibility to assess the patient's education about their medications, because most of them will be going home. They don't know when and how to take their medications. And most of this medication might, the dosage, the timing and everything might have been changed at the point of discharge. So we have to explain properly to the patients and assess the knowledge of such patients. And well done, ladies. That's just a little contribution I have. I just bumped into the discussion, unprepared, but I thought I would be able to share one or more insights from my country of practice and from the nursing point of view. Thank you so much.
Thank you so much, Tolu. I think tonight's discussion has been so rich, because not only that, we've had people in the United Kingdom, we've had some, Erica, across the ocean in the United States, I presume, and it's also lovely to have Tolu from the Irish, should I say, Northern Ireland point of view. So it ensures that it makes it solid. It solidifies the whole patient safety and medicines management, how it is very, very important in healthcare. I'm going to just round off a few things because I'm being mindful of the time, and just bear with me, just give me about 5 minutes, wrapping up what we've discussed today. There's been a lot of, we've talked a lot about patient safety. We've talked about the patient safety incident response framework. We've also talked about how it's important to work collaboratively. One thing I would like to leave us with, the 3 C's Erica mentioned about the collaborative, collaboration, collection, and concise, I think is very key. Stella, give me 1 minute and I'll put you up. And also the education. I think educating our teams in terms of the healthcare practitioners, but also educating the patients as well. It's important that we educate the patients about the medicines, the side effects, how they need to, raise any concerns, but also encourage the patients to also ask questions and report concerns as well about their medicines. Stella, do you want to put your hands up and so we can let you onto the platform? Okay, can we let Stella onto the platform, please? Hi, Stella. You're on mute. Oh, she's come back up. You need Stella, if you don't mind, you can raise up your hands. It will be put back on the platform, and then you can unmute yourself to speak. Okay, I'd assume Stella is a bit shy. So
she's not on the. She's been kicked out, I think, of LinkedIn totally.
Oh dear.
So she needs to when she comes back.
Okay, so I think another aspect that I'd like to touch upon is the medicines information aspect of it. Because from a medicines management point of view and community health services, although we do not have a medicines information department per se, it's a responsibility of ours to be able to provide effective medicines information services to our teams, or point them in the right direction, in the sense that if most oftentimes clinicians will come to me as the pharmacist asking me medicines information advice, or trying to get certain information. Oftentimes, if it's within my remit, and it's very, very important to know that you do not provide any information outside your competence or your level of competence. So different pharmacists differ depending on their experience. So oftentimes I would, most information requests, I'm able to provide them information, but also buttress it with, resources that could also, help or aid those clinicians knowledge about medicines or the area that they're researching or they're talking about. It's important that we are also educating ourselves as well, so that we get better knowledge about the medicine. So rightfully we talked about, Erica mentioned about Ozempic, for example, how it has different indications. And also Tolu Osha mentioned control drugs. Tolu, just to re-emphasize that control drugs is also a major within the England, because if anything goes wrong, we all, especially the pharmacists, we all go helter-skelter trying to find that one tablet that's probably gone missing. But it's also knowing how those information could play an important role in patient safety. So I give one example, and I'm going to be rounding up quickly, is in terms of years ago, we had an incident about a patient who had fentanyl patch on, and that fentanyl patch had exhausted the whole 3 days on the patient, and accidentally the nurse forgot to take off the patch, and meaning that they applied another patch and the patient had the other patch in situ. Years ago, there wasn't any assay to determine that, the effectiveness of a used patch after 72 hours. When I got involved with this incident, rather than giving the clinicians information that I wasn't fully aware of, it was important for me to reflect back and refer back to the manufacturers. And I can simply say, following that incident and feedback to the manufacturers, there are assays that also, or information, or there's actually been included in the assay, but there's an information in the medicines, in terms of information leaflet for fentanyl patch, that if an opioid naive individual applies the used patch after 72 hours, there is a risk that this individual might have like an overdose, or you might get some might get some fentanyl into the blood system. Why am I saying this? The sort of information that we provide is key. From a medicines management point of view, it's important that you provide this advice, or you're able to signpost effectively to the right resources. And that also, because if we are to give in the wrong information, a patient could have probably died, because they would have probably gone overdose, and you would have assumed that fentanyl patch after 3 days reduces its potency in the amount of fentanyl remaining in the patch. So we learn from this incident, and we're able to embed it into our culture about making our nurses check those patches when it's in situ, and also date those patches so that we don't have any further incident going forward. So it's in conclusion, and I'm going to conclude this now. I'm not sure if Stella is back, but notwithstanding, I think I want to say thank you so much to everyone for joining us today. But thank you so much, Erica. In conclusion, the integration of PSIRF, which is the Patient Safety Incident Response Framework, into medicines management, it offers a very structured and effective approach to improving patient safety. By this, we're able to foster transparency because we're working collaboratively. We're able to continuously learn and, adopt innovative ideas. So looking at the quality improvement into healthcare, we'll also be able to look at systematic improvement. So we're not looking at it from the person that is involved in the incident alone, but looking at it systematically, how we can improve patient safety as a whole. Also, involving the patients, I think that's key. I think there's a lot that we've had discussed today, and I'm really grateful for everyone that has been able to interact, come on stage, but actually also so grateful for those that are able to still listen to our discussion today. So what I would probably encourage us to do is to reflect on your practices at this very point in time and to say, where does patient safety hold in my practice? Where do I hold patient safety? Do I recognize the importance of patient safety within my role, within my organization? Do I work collaboratively with them? Are there any improvement plans? Are there any improvement in innovative ideas that could enhance patient safety in outcome within my organization? So I think I leave it with us, because I'm sure if we had all day, there will be loads of examples about patient safety and how we could, there are areas that you could simply say you could celebrate successes. There are areas that, Bisela rightfully said that we'll probably assume that it's all negative, but actually we can spin it on the head and then say that actually, let's think about the successes. Let's think about what we can learn. Let's think about what we can change, what we can improve on. But I want to appreciate each and every one of you. Thank you so much for giving me this opportunity, Tammy, to talk about patient safety. I think we are meeting again. We meet every Tuesdays, every second Tuesdays of every month, and that's between 6:30 to 7:30 UK time. And please, encourage people to join in. I don't think it really matters if you're an healthcare professional point of view. It could also be from a patient point of view, just to learn from them, learn about medicines and community health services as a whole. Yes. Thank you, and have a lovely evening, everyone. Tammy, last words to say goodbye.
Thank you, everyone, for joining. I was actually going to say that, if people felt that there is more to talk about patient safety, we can extend it to next month, to talk about maybe examples for ways that you've collaborated or we've collaborated that we felt that would be useful to share. It will be interesting if people think that's something they would like us to share. So show of hands, anyone think that we should come back and talk about examples of innovative ways we work on patient safety, and obviously people bring examples to share as well. Give us a love, a heart, if you think that is something you will like to hear about next month, or if you just want to totally different. Right, we got one from Dana, one from America. Anybody else? Anybody else? Cool. Obviously, we can combine it with another topic, but yes, we can. It would be good if people bring examples of innovative way they work around patient safety issues that they've come across. Because we talked, Jenkeo has talked about training. She's talked about obviously having patient experts. How did we go about even finding one? Because it's one thing to want patient expert, it's another thing to actually get one. And what will be our assessment of who we want on that in that sort of role? Because we don't want the patient to be biased as well. Because if the patient is biased, then their opinion is going to be diluted, so to say, because they just be there maybe to push an agenda. So very important that we could do that. So let us know in the comments as well if you want us. And what we are very open. So if there is a particular topic that you've had in mind around community health service, around medicine that you are interested for us to explore, please do let us know in the comments session, and then we will definitely explore those topics and look at how we can bring it back as a topic to discuss on the LinkedIn audio. Again, thank you very much. We're very sorry today. I think this is the first day we actually overrun. We've overrun by like 12 minutes. But thank you. It's been lovely having you join us and sharing your experience. And for people that are listening, and for people obviously that came on stage, we appreciate your time. We do not take it for granted. And we want to say thank you, thank you, thank you so much. And we want to believe we got value out of tonight's session. We hope that we've been able to chip in one or two things that you will take back to your practice, and obviously give it a go and see how that transform your practice. Thank you so much. And we hope to see you next month. Every second Tuesday of the month, we are here on LinkedIn and doing it again. Thank you. That's me done. Thank you.
Thank you, everyone. And we are going to go off in 3, 2, 1. Thank you.